Good afternoon, everyone. This is Sivamani. I'm a dermatologist and also an Ayurvedic practitioner and an integrative dermatologist. I'm here with, and I'll let the panel introduce themselves. I'm here with Peter and Peter Leo and Apple Bodemer. Apple is getting her camera on, but if not, she's still going to be joining us by voice. And what we wanted to do today is give you an overview of what integrative dermatology means to us, and actually more broadly, what it should mean to all of you, and then also give you a little bit of a look into what we're doing. We've developed a program called the Integrative Dermatology Certificate Program, which is really just focused on, for dermatologists, how do you take all this knowledge that's emerging in the literature and put it into a practical box so that it can be wrapped up and delivered to patients in a reasonable way that is practical. And we wanted to go over some cases on how we've been able to incorporate this into our practice as we go along. But to start with, what I'd like to do first is just have everyone give a short introduction about themselves. We're all super passionate about this area. It's something that we feel deeply passionate from a medical perspective, but also research and in terms of teaching. So let me just let everyone introduce themselves. Apple, if you would like to introduce yourself.
Yeah, so my name is Apple Bodemer. I've been in the integrative dermatology world for my entire career, pretty much. I did a fellowship in integrative medicine after I finished my dermatology residency, and have been really active in teaching through fellows in integrative medicine and the fellows that go through my academic practice and the dermatology residents here in Wisconsin as well. And I feel super passionate about, as Raja said, passionate about being able to offer integrative options for dermatology patients, and it's something that more and more every year I see patients wanting, and I'm starting to see more and more dermatology trainees, whether it's medical students or residents, being interested and curious about what else is out there.
Great, thanks, Apple. And then Peter, if you want to introduce yourself as well.
I'm Peter Leo. I'm a clinical assistant professor of dermatology and pediatrics here in Chicago at Northwestern University. I also founded and direct the Chicago Integrative Eczema Center, and I've been really interested in this for a long time. Right when I finished dermatology residency, I actually did an additional year of training in medical acupuncture with Kiko Matsumoto, and that really was an incredible experience for me and sort of started my journey properly. And since then, I've just continued to be really focused on, in particular, atopic dermatitis, but all areas of integrative dermatology and integrative medicine.
Fantastic. And I'm Raja Sivamani. I'm a board certified dermatologist as well. And once I was done with medical school, I realized I wanted to get a bit more broad training. So I went and learned Ayurveda, a 2.5-year course that I went through. And then it's just been and I think all of us will agree, it's just been this experience and journey of trying to integrate what we're learning in one perspective and bring it into the other perspective. And it's not always easy at first blush. And what we'd like to do is just show you some of the literature that's out there, how we've taken an approach to this, and then, you know, hopefully inspire you to think about taking that plunge for all of yourselves as well. So what we will be covering is an overview of what integrative dermatology is. We'll have some case-based discussions. We'll be looking at atopic dermatitis, psoriasis, acne, things that you're seeing regularly in the clinic. Probably get questions about many of these points that we're going to talk about over and over again. And we do want to highlight the Integrative Dermatology Certificate Program. We're really excited about it. I want to show you how we're laying it out. And this first version is going to be just for dermatologists. However, we are going to be creating other ones that aren't going to be only for dermatologists, but the first set will be for dermatologists. But, you know, so that you can see where we're trying to head with this. So please do submit your questions. Again, submit the questions in the area for the GoToWebinar. And if we don't get to them as we go along, we will get to them at the end when we do our Q&A session. So to start with, when we think of integrative dermatology, sometimes what happens is it gets treated as if it's alternative medicine. And alternative medicine is obviously very important. It used to be the old term to call things alternative and then conventional. And now we have this whole approach of integrative dermatology. And I think what's really important is that when we say integrative, we are referring to both conventional medicine and conventional approaches where you have controlled environments of research, controlled environments for observation, versus if you look at traditional Chinese medicine, naturopathy, Ayurvedic medicine, there's a lot of observational evidence, and I don't want to discount that as not being evidence. And people have been treating each other and being healthful and finding ways to stay healthy based on their approaches. And one of the important factors here is that there's observational evidence, and how do you merge the two together and balance that against safety? And I thought, in the next two slides, Peter, if you don't mind just going over, what your approach has been with defining integrative medicine. Peter has some nice ways of thinking about this.
One of the things that is really interesting to me is, why do patients seek alternative or integrative medicine? And I think there are three really important things that drive it for a lot of patients, obviously not for everybody, but when diseases are not curable, and that's something huge in dermatology. Pretty much everything we treat, we simply treat. We rarely cure stuff in our normal day-to-day basis. And that's interesting, because I think patients feel that, they sense that, and they want something that maybe gets a little bit deeper to the root. Right along with that, allied with that, is when our explanations are unsatisfying. And I know that it is so much stickier, it's so much sexier to use a term like leaky gut, or a concept that a patient can really get their hands around, as opposed to a really nebulous description with all sorts of science terms that really doesn't really cohere. So that is something fascinating, and it's interesting. I think science, conventional science, has really invested more time with that, with science communication, and I think we realize it's very important. And then finally, when our treatments are thought to only be symptomatic, you're not actually treating anything. All you're doing is masking it or covering it up. And I think patients feel that, and they want something that's going to address, again, the root is the background graphic here, the root cause or deeper cause. Now, how do we define this? Well, to me, there are many different definitions that you can use for integrative healthcare, but the basic concept is bringing the best conventional and these complementary approaches together in a coordinated way. So that's really what I'm out to do. If a patient comes in and says, I just want you to use acupuncture to treat me, I'd say, I'm probably not the right person. I know a little bit of that, but I mostly am still going to be based in conventional medicine. So I'm going to try to blend this for you. But if you just want an acupuncture or just want herbalist, then you should really go see those people. That's a little bit different than what we're doing here.
Yeah, and as an overview, Apple, did you have anything else to add to this? I know that, we've all had deep conversations about integrative medicine, and then we can jump into the first case.
And I think the only thing that I just want to stress goes back to one of the earlier slides, is that we really have to balance that with safety in terms of how we recommend things, and being really careful about keeping that in mind. If something is very safe, we know it's safe, and we know we really can't get into trouble, and it's got a long history of people using it and having some success, then anecdotal evidence might really be all we need. But when we have concerns that there might be more risk, then we really need to kind of tighten the belt when it comes to what sort of evidence we're wanting to look at, and making sure that we keep people safe.
Yeah, fantastic. So let's start with the case, and this is a case that that Peter has brought to all of us.
So let's begin with the case of a 6-month-old boy, history of severe eczema, atopic dermatitis since birth, that is particularly bad on the face. The family has used a number of topical steroids of kind of increasing strength. Different people have given them different options. They've even used some relatives' medicines that they brought over. They've used some topical mupirocin to get some antibacterial. They've done some dilute bleach baths. And he's actually been bad enough that they've given him several courses of antibiotics. And this guy's only 6 months old. And he's already had 2 courses of prednisolone. So they've actually gone to oral steroids, which give him really good relief for about a week. And then things come back even worse, with a vengeance. In fact, the family's really frustrated because they felt like it actually seemed to make it worse when they came off the steroids. Now, he's not eating any solid foods yet. He's still entirely breastfed.
I think the question is, for starters, just to all of us, what else would you want to know in terms of lifestyle practices or anything else that you think would be important when you're considering this patient? And so let's start by just looking at the case here. And Peter, this is pretty severe inflammation here.
Yes, I totally agree. This is a tough case, and this is unfortunately the kind of cases I see a lot now. As I've gotten more specialized, I used to be very confident with treating eczema. When I was sort of a young a young buck, I'd say, oh, we can treat this. This is no problem. And then as I got more specialized, harder and harder cases from better and better people got to my clinic and came my way. So I'm very humbled in front of it. It is a very difficult thing, but this guy looks pretty bad. And the truth here is he was using a class 1 ultra potent steroid on his face and looking like this. So one of the things the family is really worried about here is they want something alternative to steroids. They've been reading a lot about it on the internet. They are freaked out. They feel like they're using them constantly, essentially every day, both topical and systemic. And everybody they've seen keeps saying, oh, you just got to keep putting steroids on it. But they're really feeling this pressure about it. They're also worried about antibiotics because they know that it's bad for your gut flora, that it could potentially damage your microbiome. It could potentially help push resistant bacteria to come and cause trouble later. I mean, there's a lot of really good reasons why they want to avoid these things. And this is, for better or for worse, this is kind of a normal patient presentation for me. So what do we do? How do we counsel these families? What do we tell them? Because many people will simply say, well, that's it. That's what we have to offer, period. And I think part of what the magic of integrative medicine allows us to do is really to think way outside of the box and say, okay, we're going to approach this from a totally different angle. We still may need some conventional treatments to get through this, especially these really severe cases, but how can we do everything, A, to minimize the need for dangerous medicines, B, to strengthen the body? And this is one of my favorite concepts I learned when I studied acupuncture that is completely foreign to, I think, most Western or conventional medicine, the concept of strengthening or tonifying an organ system or a person. We don't talk this way, right? We don't really do this. I mean, the closest we get maybe is like a wellness checkup kind of thing. You know, we're going to check in to make sure everything's working well. But with other traditions, it's like we have to actually strengthen you. So instead of this very bellicose kind of language of we're going to smash the inflammation, we're going to kill the cancer, all this, you know, that's Western medicine's great at that. How about we got to strengthen your skin barrier. We have to enhance your microbiome. We have to, you know, get the nervous system strong enough so that it doesn't break down all the time when the behavioral pieces start kicking in. So it's really interesting to think about those angles. And then one of the number one things that I deal with on a day-to-day basis is people are very, very convinced or very worried that food is driving this. And so, especially in a case like this where it's a breastfed child, you know, what is the role of food? How do we discuss food allergies, food sensitivities? Are they playing a role? How much does it matter what the mom is eating? How strict should her diet be? Is that the answer for this patient, for most patients, for any patients? And then what else might we consider here? Could there be another differential diagnosis that we need to entertain? Should we be doing bigger workup on this patient, or should we not? Because of course, in a 6-month-old, being more invasive may actually work against us. You know, doing blood work and putting this kid through different tests may actually end up harming the child more. So I kind of think about all those things, you know, as we go into a case like this. And obviously there's no easy, simple answer, but that is something that, you know, I love to explore and go into a lot of detail. What kinds of options might we use?
On that note, Peter or Apple, do you have any suggestions on how do you address the first question point? Because we get this all the time. We have patients come in, they've been fed up using topical steroids, or they're very frustrated. What is your approach?
Yeah, with this kiddo, I mean, he clearly has some staph infection with all that honey-colored crusting. And so addressing that is part of it. Like, you can't ignore that. And there are things like that we are used to doing. Most dermatology residents learn about bleach baths and things like that as a way of helping control some of the staph. And then, you know, thinking about some of the wet wraps and kind of thinking more from a topical perspective. There are a couple botanicals that I love to use. In particular, there's one called Indigo naturalis extract, and you have to be really careful in kiddos because if you use it on too wide of a body surface area, it can actually cause liver enzyme elevation. It doesn't happen in adults. This is a botanical that we really don't hear a lot about, but it's been extensively studied in Taiwan, and it's something that I've used a lot for. There have been biopsy side-by-side studies that show that it actually can increase filaggrin, which is a protein we know is deficient in the skin of these patients when they're struggling with eczema. So that's something that I think about, you know, managing the staph with bleach or other sort of more conservative measures, and trying to really focus on that barrier, using an appropriate steroid. So overuse can get you into a lot of trouble, but he needs something to calm down that inflammation. And once that is calmed down and we get to a better control of some of that skin barrier, then it's easier and easier to maintain that skin barrier. And I think that's something that we really have to talk a lot about is once we start to see improvement, we really have to continue. It's not a time to stop either the treatments. It might be time to step down on the steroid. There are some very dilute steroid protocols that, Peter, I know you've used that include mixing steroids with mupirocin, and that can really decrease the amount of antibiotic and the amount of steroid that needs to be used. So.
Absolutely. And, you know, it's so fun. Like Indigo Naturalis is both for psoriasis and atopic dermatitis, has some anti-inflammatory effects, so it's really compelling. Another thing I actually did use in this case was a topical vitamin B12 preparation. And of course, the Indigo cream is actually this beautiful kind of purple violet color. It's gorgeous. And the B12 cream that we have made, we have both these in our office that we have had made for us, compounded for us. The B12 one is pink. So we actually call it pink magic. And it's because cyanocobalamin, the B12 powder, is like crimson red. So when you mix it with kind of a white cream base, we use sort of a shea butter type base, it's just this lovely color of pink that's totally washable. It doesn't stain clothing. The Indigo could potentially stain a little bit, but even that seems to be washable in this format. It doesn't kind of fix in the same way. But that is something we actually can use. And there actually are a couple of really nicely done double-blind randomized controlled trials showing that topical B12, 0.07% in a cream base actually has anti-inflammatory and disease-changing effects on atopic dermatitis. So really neat. So we could do that. Totally agree. Thinking about now, this case is a few years ago, but now I might think about Dr. Aaron's regime, which is the South African dermatologist who created a compound of a very low potency corticosteroid, probably on the order of hydrocortisone 1% when you finally dilute it out. That's also mixed in with fusidic acid in the UK and in South Africa, and mupirocin here, and then a moisturizer base. And as goofy as that sounds, this very, very dilute preparation is quite powerful. And we wrote a couple papers about it. One was in Pediatric Dermatology. We actually did a retrospective review of patients we treated this way. So lots of things to consider. And one of the other nice things about doing a good topical routine is you are potentially going to spare this kid from a systemic agent, because I think if we were at the Society for Pediatric Dermatology and we presented it outside of this, I think many people would say, wow, if they're using class 1 steroid all the time, we need to think about immunosuppressant, right? So cyclosporin would not be unreasonable. Of course, it's off-label. I mean, that is an off-label treatment. In fact, it is not approved for atopic dermatitis of any age in the United States, although it is in the UK and Europe for adults only. But you might use it off-label in a situation like this. But what if we could harness the power of other botanicals, treatments to actually help this patient? And that's really what I'm interested in. And then what about food? We can talk a lot about that, but in this particular case, you know, and I think in a lot of the cases I see, the way I often put it is that I'm not that lucky. I wish it were something as easy as telling the mom, hey, cut dairy and that's going to solve it. It turned out, I didn't sort of give us the background here, but the mom actually was getting increasingly restrictive over the last couple of months with her diet. And actually, she was actually having milk production problems and feeling pretty crummy because she was eating such a narrow range. I think she was kind of doing, you know, boiled chicken and rice kind of diet. She had just kept cutting everything, because everyone she met said, oh, you got to cut gluten. Oh, you got to cut the dairy. Oh, you shouldn't drink alcohol. Oh, don't eat tomatoes. You know, everybody had a view. Now she had been tested, of course, and we know that it's not a true food allergy that people are often talking about. They're talking about a sensitivity, potentially even a pro-inflammatory effect of some of the foods. But in this case, and in a lot of the cases I see, didn't seem to be the answer, unless maybe it was chicken or rice. I don't know what. Maybe if the mom starved, you know, then it would go away. But I don't think so. So that's, I think, a little bit. And of course, I don't want to dominate too much because we have some other cases. But maybe we can come back around to some of these ideas as we go further.
Yeah, you know, one thing I wanted to say in these kind of situations, especially with atopic dermatitis, is you have to ask the question, and most family members, when I talk to them, I've had referrals from actually several naturopathic doctors, and naturopathic doctors have come to me as patients with atopic dermatitis. And one of the conversations that we always have is the flared state versus the maintenance state. And I think it's really important to teach your patients about the flared state versus maintenance state. And this kind of a child, and clearly this is really flared. So if we can explain a bit more about what we're going to do in the maintenance phase. So one thing I'd like in the maintenance phase is there are a lot of oils that have been naturally shown to have anti-staph properties. We know coconut oil already naturally has it. One thing in Ayurvedic medicine that I teach my patients to do, and a lot of people ask me, oh, do they actually do this? Yes, they do, especially when you have a parent that's dedicated to the child getting better. They're willing to go that extra step. So I've done things where we infuse a little bit of neem. Neem is Azradicta indica. and it's got these antifungal and antibacterial properties in there. And usually what you do is a 4-to-1 ratio or a 3-to-1 ratio. And I usually do 4-to-1, so that's 1/5 neem powder in there. And I teach people how to do a slow infusion into coconut oil, and then they filter it out, and then you have a neem infused coconut oil. So it's got a little bit more of a ability to control and soothe the skin. That's all in the maintenance phase. And I'll go through some of this, and then I come back to this flared state, and I tell them, listen, this is where we're heading right now. I know you've done it before, but topical steroids and antibiotics are going to get you to this next phase where we can really try to focus on keeping things clear, so that you're not struggling to clear things, and so that there's not a long, drawn-out process to clear the skin. And by and large, it's very few parents that'll say, okay, no to the steroids at that point. Even if they're steroid phobic, they're willing to go into the steroids because they see that there's a path going forward. And one of the interesting things about Indigo naturalis is that it inhibits IL-17. They've shown that in several studies now that it has IL-17 inhibition. And, whether that's useful in atopic dermatitis remains to be seen, but it's kind of an interesting little tidbit. So food allergy testing, IgG, we can buy these kits over the counter, guys. Does anyone show up saying, hey, I got my Everywell kit, or I got my kit from Target, and here are the 18 foods I'm allergic to? Do you ever find it useful as a starting point to do food elimination, or do you say, hey, listen, just keep a diary, or like what are your approaches when people are really focused on food?
For adults, I'm much more comfortable with them kind of excluding foods and playing around with it. I get a little more protective of the kids, in part because people can be pretty cruel, with the best intentions. They can really cut down their diet and their intake. And I've had a couple of patients in my career where they've actually had kwashiorkor or other nutritional deficiencies because they've really starved the kids from the proper nutrients. So I think it can be dangerous. More importantly, Anne-Marie Singh in Wisconsin recently published a paper that was pretty amazing. She actually found that families and patients who exclude foods presumptively, in other words, they're known not to be allergic. She's done the baseline testing, but they said, I just want to try it, right? Something that I'm sort of even advocating here. If you want to try, go ahead. What she found was that a significant percentage of them over time developed actual type 1 hypersensitivity to the food. So to wit, hives, potentially urticaria, and even anaphylaxis in some patients, along with the angioedema. So what her point was, just as we saw in the famous LEAP study, where they demonstrated that kids who ate peanuts early were protected and therefore, seemed to have a lower likelihood of developing peanut allergy. The secret is to eat it, to tolerize it. The same principle is thought to be at play. If you exclude a food, your mechanism of tolerance can disappear. And if any of that food's in the environment, which it is, we're kind of covered in dust, it can transcutaneously penetrate and you can become sensitive to that. So there may be a real cost to just cutting out foods, giving them sort of their worst fear made real, right? They're so afraid that they're allergic now. In their minds, they're saying, I'm afraid it's driving the eczema, but now, holy cow, now you actually have anaphylaxis or angioedema or urticaria to it. So that's why I'm a little more careful. So I think diaries can be really helpful. I really also think there's a wonderful paper from John Hannafin from the 80s that I love, where they hospitalized families who were totally convinced it was food, and he got them better using conventional things, getting them better, and at the end of that hospital stay, more than 80% of those patients and families who were convinced it was food agreed. They're like, yeah, I guess it's not food. Like we're pretty good now, so I think part of our job is to meet them, get them better, and see if it really is. Because the other hard part is if your skin is out of control like this guy, how can you tell what's making him bad? Everything can be making him bad. If he eats anything, gets on the skin, it's irritating, anything. So it's like I often say that threshold of the sort of the level, we have to get them better so that the threshold is a little bit raised. Right now, their threshold's so low. The littlest thing will set them off. If I can get their skin a little stronger and better, then we'll know, was it actually carrots? Was it actually tomatoes? Was it really dairy? Or were those just things that happen to happen, coincidentally?
Yeah, thanks, Peter. So, we have some questions coming in. I'm going to go to the next case, but I'm going to hold this question to the end. But I'll remember that I just want to acknowledge that I do see a question that's come in. Let's go to the next case, though. Case 2. And Apple, can you take us through this case?
Yeah, so here we have a 56-year-old guy who's got psoriasis and has long kind of history of it, and he's started flaring up. He's got some joint pain in his hands that sort of get worse over the day and get better when he rests, and a little bit of stiffness in the morning that improves as he kind of gets going. So the kind of things that when you see this, he has pretty extensive body surface area. There's some areas of clearing between, but in terms of how much he would need to treat topically, that's quite a large area. And kind of approaching with this guy is, you know, a lot of times these people have psoriasis for a long time, and they maybe have been treated with topical steroids alone and not given drug holidays from the steroids, and they kind of get frustrated and are kind of give up for a long time. So he may or may not have been treated for a long time. But I think kind of the questions that we really want to ask him, we really want to focus too on what else he's doing in his life. The lifestyle questions are really important. Things like smoking. Most of these people know that they shouldn't be smoking, but it gives them sort of one more impetus to try and quit, and to talk about, like, have you had success in the past, and really try to draw out where they're at in the resistance level of terms of trying to stop smoking. Because obviously if we can get him to stop smoking, that could impact his psoriasis, but will have huge implications on his overall health. Asking about alcohol intake and diet are also really important. You know, this guy is not overweight, but a lot of our psoriasis patients are, and we do know that reducing weight, just weight loss alone, can improve the psoriasis.
Apple, I have a question for you on that. I've been told that the number one way to get a bad Yelp review or a Google review is to open your discussion with weight loss. How do you approach this? Because obviously weight loss is a big deal.
It is. It's a big deal on so many levels, and I don't approach weight loss directly. I start talking about their diet with them. And this is a thing that often takes a while. It takes a little bit of getting a sense of where the patient's at, how they want to approach their disease, and getting a good sense of what their overall health goals are. And then I really approach it from looking at how are you eating and diet as a pattern of food intake rather than you need to lose weight kind of thing. And you know, if we kind of talk to this guy and he's eating a ton of dairy, where I live in my neck of the woods in Wisconsin, it's, you know, dairy is its own food group at the bottom of the pyramid, and lots of people eat a ton of dairy, and that it's a very inflammatory food for many people and not everybody. But that's sort of a thing to get a sense of the processed foods that they might be eating, and kind of encouraging them to eat more plants, giving them resources and support, places to find recipes. And I always tell people I'd rather see you make small changes over time than go out and totally change your diet and do that for 2 weeks and then get frustrated and go to a barbecue and give up everything. So I really encourage people to sort of nudge in the right direction or lean into dietary changes. And then as you build a relationship with somebody, then talking about physical exercise and stress, all of those things come in. It's not something that's easy to address in one visit unless I have a really extended integrative consult visit, which can sometimes be 40-45 minutes. And those people tend to be more motivated. So having a conversation about diet and exercise and weight loss tends to be a little bit easier when they come in already buying into a big sort of lifestyle overhaul. But for the general run-of-the-mill psoriasis patients, that's how I introduce it. Kind of just to start talking about what are you eating on a regular basis, focus on one thing at a time, and gradually bring in things like increasing plants, decreasing pro-inflammatory foods, increasing exercise, and then, you know, sometimes the weight will come off.
And then anything you have to add on this one, Peter?
No, I totally agree. These are such tough cases too, because I think with psoriasis, a lot of times people suffer in silence. With atopic dermatitis, they're much more vocal, but I have so many patients where, you know, say, look at them and say, how long have you been dealing with this? And they say, oh, years. You know, some doctors gave me some triamcinolone years ago, but it didn't do much. It would only work for a while, so I kind of gave up. And in a way, now it's kind of an exciting time because we have so many options for them. You know, all the companies are falling over each other with new and improved biologics. We have new oral medicines. We have great topicals. And then we pair that with the world of integrative. There's just endless opportunities, and I really love that, including phototherapy, which is one of my favorite modalities for this kind of a situation.
Yeah, especially for somebody that's wide.
Oh, go ahead, Apple.
Oh, I was just saying, especially for somebody with this much widespread psoriasis, if it hasn't been treated with phototherapy in the past. And what Peter said is really important, and this is, I think, brings in what integrative really means. Is it doesn't mean we're not going to use biologics. It means when we use them, we're going to do them safely. And pair it with other lifestyle changes and possibly other herbs and things that might help them improve quickly and get them clear, and sort of reassess and see, like, yeah, maybe they've been on a biologic for many, many years, and in that time maybe they've lost 20 or 30 pounds and they've quit smoking, and then is that a time maybe we can try going off of a biologic and seeing how they do. That we use these really aggressive integrated Western approaches to get somebody back to feeling better, and a lot of times that'll spur on lifestyle changes that will have positive impact on the disease. So
now, one of the things in this particular patient that I find notable is that the joint pain doesn't seem to fit for a standard psoriatic joint pain. It may be just osteoarthritic joint pain. I'd want to just get a better idea of where they are with that joint pain. Understand, does this come and go? Is it seasonal? How does that occur? But one of the herbs that I like to incorporate in this kind of a situation would be turmeric or curcumin. One of the misconceptions around turmeric is, and we use it a lot in Ayurvedic medicine too, is that you need to give it with black pepper. That's curcumin. Curcumin you need to give with black pepper because that helps curcumin absorb. But they've done a study before where they actually cross-compared curcumin's ability to absorb when it's given with black pepper versus giving the curcumin with the non-curcumin related other components in turmeric. And what they found was that the other components in turmeric actually help curcumin absorb better than black pepper helps curcumin absorb. Now, the thing about turmeric is you don't have as much curcumin that comes in, but usually the dosing that I do for people with psoriasis, and I tell them you might get a benefit with their joints, is you have to go up to about 4,000 to 6,000, which is 2 teaspoons up to 3 teaspoons. And one of the things that I find when I talk to my patients about this, and I have all kinds of folks taking it, like big burly guys that come in, or the folks that are a bit more dainty or whatnot, it doesn't matter. They're all very interested. Once they start taking the turmeric and mixing in with something like almond milk or whatnot, I start talking to them about activity and phototherapy. And as they continue to or start to get better, and many times we'll put a lot of these patients straight to phototherapy. I don't necessarily go straight to the biologics. I'll actually talk about phototherapy first. That, well, maybe you can start going outside more and going on hikes more, or something where they're getting that sunlight, but they're doing it in an active form. And I feel like sometimes getting people to do a regimen with an herb kind of stimulates this whole new mindset of, oh, I'm going to take charge of how I'm going to approach my health, and then get them to really think about activity as well. So that's just another thing that I've started to incorporate in all my conversations. And it just takes like a couple minutes in the room, and gets them going on a different trajectory. And you're seeing these patients back frequently that you can re-venture into these conversations. So
I wanted to, go ahead.
Yeah, please. No, please go ahead. I was
wanted
going to actually do the case scenario change that you had put together, Apple, as well.
I'd love to talk about, and I want to go back to just the turmeric, because people come to me and say, they want to go and buy the highest quality curcumin supplement that they can. And I always tell people, I'm fine with that, but I also want you incorporating turmeric in your diet. And I send them home. I've got some smart phrases that I just pull into some recipes that they can get started with, that are easy, like very palatable, that my kids even like. And that really to drive home that the whole spice has way more benefit probably than an isolated compound. And especially in Western medicine, we're really great at isolating compounds and finding the strongest component. But the synergistic effect that occurs with whole herbs and spices is really powerful, and it often gets underused. And then also that kind of tying into the diet, like rosemary is really a good anti-inflammatory as well. Oregano is a good anti-inflammatory. There's lots of really great anti-inflammatory spices. So for those people who are like, yeah, I don't like the turmeric, I have some people with really sensitive stomachs and too much of it will upset their stomach, then I ask them to incorporate just a combination of spices into their cooking. And then it gets them thinking about cooking at home and more about where their food's coming from and what they're putting in their bodies. And this woman is one of my favorite patients that I've ever taken care of. She came in as, she would hate it if I described her this way, but I think you'll all know what I'm talking about. Sort of a doughy, grandmotherly, very soft woman who, is probably somebody who's going to take care of everybody else before she takes care of herself. And she was recently diagnosed with prediabetes, getting close to diabetes, and she also had a new onset psoriasis that was biopsy proven. And she hadn't been really treated much. We talked about what we could do, and I talked a little bit about topicals. I did give her a steroid to kind of get started with, but we talked most of the time we spent about diet, because she was really afraid of going on insulin, and she had heard from her doctor that she was headed towards orals and that she was going to be going back to her doctor in about 4 to 6 months, and that if she didn't do a good job with shifting her diet and getting better control of her blood sugars, she was going to be on that path. And she had watched her mom die from complications of diabetes. So we talked about diet, and I really kind of drove home that I thought a whole foods plant-based diet would be very important for her, because of what we know about how a whole foods plant-based diet can impact the cardiovascular system and the comorbidities with psoriasis, including depression, heart disease, other types of inflammation. And so we talked about whole foods plant-based with an anti-inflammatory component. We went through all of the anti-inflammatory herbs, and I left the room thinking, she's never going to do it. She's just never going to make all of these changes. And a couple, I think I saw her 4 months later. She had lost 10 pounds. Her hemoglobin A1C had dropped like 4 or 5 points, so she was no longer in that prediabetes, diabetes category. Her doctor couldn't believe what she had done, and was like, well, if you keep this up, you won't ever, you'll never get diabetes. You're kind of taking yourself out of that. And her skin had cleared up significantly, not completely. And so she was really grateful and really happy, and committed to this lifestyle and this diet change. And I gave her a lot more resources, and she would message me every once in a while and ask for another resource here and there. And I have smart phrases that I could do that. And I hadn't seen her in a year. And just this last Christmas, I got a message from her telling me that she kind of got to a point where she decided the diet wasn't really doing all that much for her. She didn't think she needed to do it. And over the holidays, she went off of it. Within 2 weeks, her skin flared up, and she started having all kinds of symptoms. Her gut was really feeling bloated. She had gained more weight than she expected to. I think she'd gained like 3 or 4 pounds in this 2-week period, and she felt awful. And she went back on the diet, and her skin cleared up within a couple weeks again. And she, this is somebody that she told me, I'm so glad you told me about this. I would have never known, and it's changed my life. And this what happened over the holidays is just proof that I need to keep doing this for the rest of my life. And I think what I get so excited about is that we took her away from diabetes. Like, she was headed towards diabetes, and her motivation to improve her skin, along with the motivation for her overall well-being, she was able to do it. And I mean, I didn't do it. I just gave her the information. And a lot of times what I'll tell people is, you don't have to make any of these changes, but I don't want you to look back in 10 years and say, I wish somebody had told me. So that's kind of another way that I talk about it with patients. And
yeah, thanks for sharing that case, Apple. And I think one of the things that's important to realize is that it's not just Apple that's been looking at diet. There's been actually a meta-analysis looking at the role of diet in psoriasis. And as you can see here, multiple studies that have looked at weight loss, and you can see the amount of weight reduction that many of them went through. Overall, what the grand result is that you have a 2.92 greater odds if you lose weight, regardless of what intervention you are, of the proportion of patients that reach PASI 75. So if you lose weight during any sort of intervention, you increase your odds of getting to a PASI 75 by that much more. So I find this very relevant, even when we're talking to our patients about biologics, or if it's, an IL-17, IL-23, if it's a TNF inhibitor. We know that not all of them are going to get to PASI 100. The data clearly shows that not everybody's getting to PASI 100. Many of them are getting to PASI 75. But what I try to tell them is that if you can really focus on diet as well, that might give us more tools to then hopefully maybe even start decreasing the dosing that we do and whatnot. So I thought that was a really interesting tidbit there. Why don't we go to the next case? And this is a case of a 25-year-old woman with comedonal inflammatory acne, something that we all see pretty regularly, flares with menstrual cycles. She's tried antibiotics. Of course, these are very hit or miss in these menstrual cycle flared acne kind of situations. And she's currently on spironolactone. She would like to avoid isotretinoin now and may want to have children within the next 6 months. So clearly isotretinoin is not going to be a good option because she's still on the fence. And even spironolactone, we may need to start thinking about, are we going to keep that up or are we going to bring that down? And the question is, what else would you want to know? So here's a characteristic kind of a photo. Many comedones scattered everywhere, pretty inflammatory. And so the question is, what are the other options that are available to consider? And classically, what you would say is, well, if you've got spironolactone, the first question is what dose? And many folks will stop at 100. I have taken people up to 150, 200, but I think what you need to know is there any chance of PCOS being involved here? Because then you could integrate metformin into whatever treatment protocol that you're going to do. So I think that's really important to assess for. And the other question is, what are the roles? So I'd want to know what topicals she's using and what orals that she has tried before. If it's particularly inflammatory, our natural tendency has been to do recurrent flares of antibiotics. But there's been more and more studies coming out about several probiotics. And one of the probiotics, and I'll mention here, it goes by the brand name, and I only mention the brand name because it's the only one that's had a randomized control study against antibiotics. And the antibiotic it was studied against was minocycline 100 milligrams daily, not 200 milligrams, but 100 milligrams daily. And what they did was they studied it in adult women with acne, and it was called Healthy Trinity. And it's a probiotic with 3 different strains in there. And what they found was that it had similar effects to the antibiotics, no cases of vaginal candidiasis, and if it was used with antibiotics, it was synergistic in both the comedone and basically the comedones and the inflammatory lesions. So I talk about probiotics with a lot of these women, especially if they're thinking about childbearing or if they have some aversion to isotretinoin or they're taking their time to think about it. I do let them know that if they don't have any other contraindication, the isotretinoin really is a really good option. And the other herb that I like to build in, and I do ask them about diet, and we'll get into that. The other herb that I love to build in is an herb that goes by the name of Shardunica. And it's known in Ayurveda as Gurmar, G-U-R-M-A-R. Shardunica is S-H-A-R-D-H-U-N-I-K-A. And it has gymnemic acid in there. And if any of you are familiar with it, it inhibits the sweet taste buds on your tongue. One of the questions people ask is, why the heck would you ever want to do that? Then you won't taste anything. And it's true. If you ever want to do a horrible party trick, have people take this herb or put it in something that they're going to drink and then give them Hershey Kisses. Everything tastes like butter and totally loses all its flavor. But what is done is it's built into regimens when you're eating. It actually will inhibit the amount of glucose that gets absorbed. So if you're eating a high glucose diet, you're trying to find ways to reduce the glucose load getting in. This is a method that you can use to reduce how much of a glycemic index any food is going to have when you take it. And there's very few side effects with it. It doesn't cause a bunch of flatulence or diarrhea in a lot of people. And there are few sources that you can buy them from. But I literally have several patients that are in this exact same scenario that are going towards childbearing, and they don't want. And by the way, there isn't any known birth issues, at least in the Ayurvedic literature. Probably need to study that a bit more in terms of pregnancy, but especially in that time period when they may be dealing with PCOS as well. I think it's a nice herb to add in. Do either of you have any other points? I know we're going to talk a little bit about diet mass and data to present, but I wanted to see if either of you have other ways that you might approach this, other things to think about.
There's a wonderful paper that I came across a number of years ago where they had adults who had PCOS and had kind of hirsutism. They had them drink spearmint tea, so just spearmint tea leaves, brewed. You can just get it at any grocery store, 2 cups a day, and they actually showed a significant improvement in the hirsutism. They showed improvement in the LH and FSH. And when I thought about that, I thought this might be useful. So I've been using that sort of slightly off what the study was for this hormonal acne, which has been really interesting.
And the other thing that I've used that really doesn't have much good evidence at all is a herb called maca root. It's been used for hundreds of years by traditional herbalists to increase libido, and it does that for everybody. But especially with this hormonal acne and kind of women that we see, especially kind of more towards middle-aged, it sometimes is a desirable side effect and sometimes not. So it's something you definitely have to counsel patients about. but and it can cause some upset stomach if they start taking too much at one time. But I've had some really good results with that. And it's one of these herbs that I don't understand the tonics. It's somehow it normalizes androgen levels. At least that's what it's supposed to be doing. And I definitely see clinical improvement in a lot of my patients that stick with it. But like I said, you kind of have to let people know about that increased libido, and because it is unexpected.
Just to expand, thank you both, Peter and Apple. Just to expand a little bit about the gut-skin axis. I mean, one of the things that you probably hear us talking about is, and this isn't just about acne. I mean, any of these conditions, we're thinking about what they're putting in their body and how that might affect what's getting secreted into the system and how that gets back to the skin. Well, you know, we've seen a lot of epidemiological studies around protein and I guess dairy, I should say, more dairy consumption and acne. Well, here's a study that came out of Brazil looking at protein supplementation. They followed people as they protein supplemented, and they didn't go in there and see which ones were whey, which ones weren't whey, but predominantly they make the comment there that was predominantly whey protein that was being consumed. And what you can see is they tracked people overall. In the left panel, you can see the total lesions per person went considerably up. I mean, you're talking about almost a threefold increase from month 0 to month 2. And then when they broke it apart between males and females on the right panel, what you can see here is that, again, regardless of whether you're female or male, you can definitely see that there was an increase in the lesion count, and it was a considerable increase. So one of the things that was done later on was a meta-analysis looking at all different sorts of dairy products, not just milk and not just whole versus low-fat skim milk, but looking at, you know, what is the overall effect of any dairy product and how does it affect acne? And what they found is that across the board, any of the dairy products can actually stimulate acne to be in a worsened state. So when I talk to my patients, and one of the things about low-fat skim milk is that, and this is in California, and state by state they have different regulations. When they pull the fat out of whole milk, they have to put a filler back in, and that filler frequently will have oligosaccharides, will have whey protein, and it may have things that stimulate the insulin cascade. So it's no surprise that actually skim milk and low-fat milk have had the higher association through many epidemiological studies. But I do talk to my patients about going dairy-free and even cheese-free, and many of them tell me that taking out the cheese has made an effect. I do make some exceptions that allow them to have goat cheese. Not that there's good evidence, but usually the cheese that is studied is predominantly cow cheese. But it's one of those things that I do talk to people about going dairy-free if they're willing to do that. And many of my patients are definitely willing to do that. And then finally, there have been case reports where they've looked at and followed people where they were given whey protein supplementation. They watched them flare, and then they had them come off the whey protein, and then they got better, and then they had them redo the whey protein because the patient said, hey, I want to get back on my whey protein, and they flared again. So we definitely know that whey protein is something that you might want to ask your patients about. When I was in residency, we used to think it was all anabolic steroids or something that they may be injecting. Well, now the new thing to look out for is whey protein. So make sure you ask your patients about whey protein. And finally, the mTOR pathway in acne is something that has garnered a lot of interest. And there's this idea that there are many different inputs that are going into the mTOR pathway, whether it be high meat intake or whether it's high milk intake or dairy intake or just the glycemic load. And we didn't talk about any of that data here, but study after, there's been a couple studies, but several studies have shown that high glycemic load foods are not good. And in fact, low glycemic load foods may be beneficial. Well, one of the questions that has come up, and this is a point that I raised for all of you to think about, is we talk about the mTOR1. There's two different drivers of the mTOR pathway, mTOR1, the mTOR complex 1, and mTOR complex 2. And what's been found is that when people are put on sirolimus, which is an mTOR1 inhibitor, it has flared acne in people. So it's not clear-cut that if you just block the mTOR1 complex, that will actually improve acne. In fact, the evidence has been on the flip side that it may actually not. What it does is it may actually drive the mTOR2 pathway, and then it may still lead to worsened acne. And in fact, the case studies have shown that in folks that had never had acne before, when they get put on this for immunosuppressive reasons, they flared with acne. But and we've published on this, there are many botanicals like quercetin, EGCG, which is in green tea. There are many botanicals and phytochemicals that are able to block the mTOR1 and mTOR2 pathways. There are no pharmacological agents that can do this right now. Another reason to have a conversation about healthy foods and some supplements out there that may be useful. But it still remains to be seen what is the role of this, but it's something that has garnered a lot of interest. And then, Peter, I know you wanted to touch upon the cannabinoids.
Yeah, so a very, very hot area right now in all forms of medicine, but now it's getting to dermatology, are cannabinoids. So these are a whole host of molecules that are derived from the hemp plant, which we know is the same as the marijuana plant. And of course, they're the same species, but they're bred two different ways. Those that are less in THC and a lot of the cannabinoids are, and more for their fibers, are the hemp ones. The ones that have been bred for having more THC and other cannabinoids are the marijuana plants. But cannabinoids are fascinating because they have receptors all over things in the skin, from the fat cells to the hair to inflammatory cells and also to nerve endings. There is potential for tons of different effects: anti-nociceptive, antipruritic, anti-inflammatory, and some interesting effects with acne. So I think our next slide is really interesting. This was...
Oh, Peter, I didn't include that slide, but if you can describe it.
I'll describe it. It was a neat experiment where they actually found that there are some endogenous cannabinoids that our own body makes that actually can drive oil production from sebaceous glands and from sebocytes. And what they found was that CBD, cannabidiol, when you put that in the same milieu, it actually decreases oil production. So it turns out that cannabinoids may have anti-sebum effects, which would be really great for acne. So you put anti-sebum, anti-inflammatory. It also has some effects on decreasing proliferation. Well, now you're starting to describe the entire pathophysiology of acne. It's kind of amazing. So there is real promise for this. There are not any good clinical studies yet available, but I do know that some are ongoing, particularly in the world of atopic dermatitis, but also in acne. And this is definitely an area to stay tuned.
So before we get into the certificate program, I did want to just let everybody know that all the discussions that we have here, it's non-CME, but you can see that we're really focused in on studies, we're focused in on mechanisms, and I think it's an important aspect of how we think that we want to do this. Now, I want to get to some of the questions before we talk about this. There was a couple questions in here. So one of the first questions was, what was the concentration of topical B12 cream for the atopic dermatitis patient? So maybe directed towards you, Peter.
Sure, I can send you the recipe. In fact, if you just go online, if you Google my name, Peter Lio, L-I-O, and Pink Magic or vitamin B12 cream, it'll come up. I wrote a whole article about it and a few different ones, including for National Eczema Association. So you can get a full recipe, and any compounding pharmacist should be able to make it for you. We have it made in batches, so we just sell it from our office. We have a whole bunch made, but I've had patients who don't live nearby. They can just get it from a compounding pharmacy. So we can send that along.
Fantastic. Now, before I get to the other questions, let me just talk about the certificate program. So this is really designed to expand your skill sets into areas that we know weren't covered in residency, but we know that patients are asking about. And right now, it is for dermatologists. However, and there have been questions on this, we are going to release a program that is going to be open to all, like physician assistants, nurse practitioners, naturopathic doctors, physicians, so that you have a good broad knowledge about how you can talk to your patients about the most common things. And then this one will go into some of the esoteric. But let me give you an idea of what we're going to do with this program. It's a 9-month program, self-paced online, although we do ask you to keep up because there will be a midterm and a final exam as part of this program. There are weekly office hours, which are going to be much like this, where you bring cases that you have had challenges with, or we will bring cases. And then we discuss them, and many times we'll try to bring in guest experts as well to wrap our head around maybe some difficult cases or some new perspectives that they are really experts in that can help you expand your knowledge base. And we've split it up so that there's going to be a whole section looking at fundamentals, and I'll show you what those fundamentals would be focused on. And when I say fundamentals, it's across the gamut of integrative medicine, not just focused on skin, but so that you have a good broad basis, because there are many topics that we know we haven't learned before, but we'd like to set the baseline for this. And then we focus in on the diseases. and then really delve into all the little facets in there. And that's where we're going to be building the integrative toolkit, this toolkit model that if you can take the pathophysiology of any condition, and acne being one of them, where you have proliferation, you have sebum production, you have inflammation, you can fit any of the other perspectives in there neatly so that you can synergize better. And it makes it practical so that you're not left trying to figure out, well, how do I use all these pieces one by one? And then finally, we want to also give you some tools with business and entrepreneurship. So we are going to be bringing on some lawyers to talk about what are the legalese about how you set up entities, or if you want to do skincare lines, what are the nuances that are in there. We'll bring in some formulators to get you guys connected. And not only that, also talk about what are the difficulties in doing certain formulations, and also compounding pharmacists, so that you have an idea of if you want to try to build in some things into your practice, or get some things that you want to make available either to sell from your practice or just send to your patients, what are the limitations or the abilities with compounding? And then we do some in-person intensives. We'll see how things go over the course of this year. Will it be in-person Zoom intensives, or will they be in-person intensives? But we're expecting to do them as in-person intensives. That's where the fun comes, where you get to taste some of these herbs or work on different sorts of mind-body practices together. And so we really bring that to life. And our goal here is to create a community where you will continue to then inspire other folks and other practitioners around you to do the same thing. And when we talked about the curriculum, we wanted to be comprehensive. This is some of the fundamentals where we introduce the toolkit and go through a range of topics. Herbs and botanicals isn't just in. We'll talk about what are the different kinds of herbs and botanical classes that are out there. With nutrition, you'll get a flavor, no pun intended, a flavor of all the different kinds of diets that are out there. Mind Body will talk about things like energy medicine, what are meditation methods. So, you can look for yourselves, but we also touch on things that you're going to see on a daily basis. Ingredients, what's in your skincare? What are those ingredients doing? Not only are there botanicals, but what about emulsifiers? How do you think about that when you're looking at skin types, or different sorts of ingredients that may be used just from the synthetic world? And then, of course, integrating pharmaceuticals with herbs and supplements. Obviously, that's the key. We want to integrate, not try to teach you to move away from conventional medicine. It's that we try to bridge it all together. And so it's thought with a practical application in mind so that you can incorporate it right away. This program right now is developed for derms, and we're dermatologists, so we do know where a lot of the clinical questions are, where the struggles tend to be. And then we really want to build a supportive community so that we're all coming together. And then finally, to finish up with some of the questions that we had, so there was another question here. I wonder if the parents were disclosing all the products that they were applying to the child, and what was the mother applying to her breast area? So again, directed towards you, Peter.
And I wanted to say thank you, Vanita. I think you put up the recipe for Pink Magic, the link to the article there. So it's in the chat room.
So, but Peter, I wanted to see, is there a question? There was a question for you. The question was, I wonder if the parents were disclosing all the products they were applying to that child that you presented that case, and what was the mother applying to her breast area? Do you know if there's any further information on that?
Yeah, no, they really weren't. It looks like a contact dermatitis. It kind of does, but yeah, they weren't putting anything. I mean, as far as I know, they weren't putting anything extra on. And the mom didn't have any breast issues, so she wasn't using any product in that area. But that's a great point. The kid actually did have significant eczema around the whole body. It's just the face was worse, but he had pretty widespread disease all over.
And then we have another question here. Let me send this one to you, Apple. Any go-to probiotic brands for patients that don't eat Greek yogurt or kimchi?
There's so many out there, and there's so many different price points. I think that's something working in an academic practice where I see sort of all comers. I'm sensitive to that. Probably there's the one that Raja mentioned is a really great probiotic. I think even the Florigen and Culturelle, which are really widely accessible and easy for people to get, those are pretty good ones too. There is one called K-Dur. It's a refrigerated probiotic that's really high quality as well. Usually you need to be going to a specialty health food store in order to get that one. So that's kind of what you want to make sure that it's a live culture. and that I always tell people, look for the USP seal. That United States Pharmacopoeia seal is, and it looks like I've got a low battery, so I'm just gonna plug my computer back in. But that tells you that the company has gone through third-party quality control, and it gives you a good sense of, well, this is probably a pretty decent product, at least. You know, so you have people going to maybe Walmart or Walgreens looking for something that fits into their price point. They can, you know, there's a lot of variability in the products that are out there. And the interesting thing is there are some of them that people argue whether they might be dead, although we're learning about what we call these postbiotics now. And these are sometimes inactive probiotics or products that come from the fermentation process that probiotics do in the gut. And they may have some biological activity. So even if they're getting a low quality product, they're probably not going to get the clinical benefit that we're really hoping for, but it may not all be lost. And that's like new research that's ongoing, and it's a really interesting field.
So with that, I'd like to thank all of you for attending and checking out what we're trying to accomplish with Integrative Dermatology. Again, just as a reminder, the program is going to be starting June 1, and the application deadline is May 24th. Please check it out. You do get CMEs, and not only that, we've built in so that you can get pain CME and also ethics CME as part of this course. And then finally, I will say we're going to be releasing another program not too far in the distant future that's going to be available for non-dermatologists as well. So if you're very interested, let us know, because we can get you on that wait list for that as well. All righty, everyone. Thank you, and hope you all have a great night.
Night, guys.
Night.